Hello everyone, and welcome to today's presentation on boosting or enhancing productivity in an ICD-10 world. My name is Karen Scott and I am here with you today. My job title is TruCode Senior Training Specialist, and we've tried to put together some different webinars throughout the year to try to assist you guys in helping you with your coding and that kind of thing. And so we hope that you will find this to be a helpful presentation today, and we do appreciate you guys being here with us for the next hour to be able to go through this information. Now, just a little bit of housekeeping before we do get started. You will notice on the control panel, which is on the right hand side of your screen, you will notice that there is a little orange arrow or orange box with an arrow in it, and that is where you can click that to open or close that control panel. If it's in your way and it's over some of the material I'm talking about, you can simply click that to close it. That's the best way to do that. However, if you do want to ask any questions today, you are all going to be in listen-only mode. So the way you can ask questions is you can go down toward the bottom of the control panel. There is a little plus sign that says questions. Once you click on that plus sign, it'll look like it does here on the screen. It'll turn from a plus sign into a minus sign, and it'll open up and it'll say enter a question for staff. If you have any technical questions, Sharon's in the background. She is there to be able to check to see if you have any problems or questions there. And if we have time at the end of the presentation, I will try to answer your questions. If we run out of time or you don't get a chance to ask your question, we will go through those and we will answer those after the presentation as well. So please let us know to go ahead and ask it as we go through, and we will try to get to those as well. A couple of things also down there just underneath the questions, and I don't have a slide on this, but just underneath questions it says handouts. You can click on the handout button and then you can simply print your handouts or save it onto your computer from there. So again, it's on that control panel. At the very bottom of your control panel underneath questions it says handouts, and that's where the handouts are available, and we are recording this presentation today as well. Please remember too that you will get CE certificates. They will come out tomorrow, and so that's another question people ask, is that I know I'm getting CE credits for listening today. How do I get those? You will get those tomorrow. So that should answer the housekeeping questions, and if I forget anything else, I'll try to remind you of those again at the end of the presentation, but I just wanted to start with that today. So if the little control panel is in your way, just go ahead and click on the little orange box and move it out of the way, and then it will get out of your way and you'll be able to see the whole entire screen. So let's go ahead and get started. So our objectives today are, we're going to talk, this is a really technical slide here, things impacting productivity. I knew you'd appreciate that. So basically, just our objectives are, we're going to talk about things impacting the productivity. I know that we've had a year under our belt now of ICD-10. I think that it's gone so much better than we ever dreamed it would go, but there's still ways that we can do a little bit better job. And so I'm going to go through some things just from my work over the last year or so, talking to clients, looking at areas that have been problematic for them. Again, a lot of the areas that we thought were going to be problematic were not as much, but we want to talk about some of the areas that you may look at some of these and go, oh, well, we do that. We've already done that, or that's a consistent thing we do all the time. But there may be some things when you go, well, we hadn't really talked about that. So I'm hoping that even though some of this stuff might seem like common sense, trying to help think about all the different areas that can impact productivity and help to be able to make sure you're addressing it in your facility. Of course, whenever we're talking about productivity, we have to talk about documentation improvement. So we got a little bit of CDI in here as well to help make sure that your CDI program is good, and if it is doing any better, since we've moved over to ICD-10. And then talking about some new ideas. And one of the things that I want to bring up is just maybe a different way to code an ICD-10 PCS, because that is probably what's caused people, if you've got an area where productivity is suffering, that's probably one of the areas that we see the most, because ICD-10 is just so darn different from what we have used in the past. And there's, we've got information, but we're waiting on information from coding clinics, and we don't have all the years of background that we had with ICD-10, because a lot of the rules were the same as they were in ICD-9. So we're going to talk a little bit about that as we're going through today as well. All right, so some of these first slides are things as I was going through and finding new material, I pulled out some of my previous material about the things that we talked about before ICD-10, that we said these are the things that you need to be addressing because these are the things that are going to impact your claims, they impact your reimbursement. And so I did that from a couple of different approaches before ICD-10, one from a coding perspective and one from a financial area as far as claims. So this slide was just a reminder, and again, these are things you may have already done, hopefully you've done that, and that you're continuing to do. If you work in the coding world, this may not be your main priority, but hopefully somebody in your facility has been looking at these. So first of all is that you should have done before and have continued to do, and now analyzing the impact on claims. But we need to be looking at those claims, and I'm going to talk a little bit more about that in just a little bit, because we know if there's incomplete documentation, the coding can be inaccurate and the claims can be impacted. We've seen rejected claims. I've seen physicians that will they'll get their EOBs back and it'll say we're not going to pay this because you need to have a more specific code, and then they don't know what to do with that. So we'll talk about some of those stories as well, because I always like stories. We do know that there's still, even though we've been working on this, we still know there is a disconnect between the physician language and the coder language. They don't have to think, especially with PCS, there's a lot of things that the doctors don't have to say, that the coder has to interpret, and that makes it a little more of a difficult process, and the coder's got to get more comfortable with the terminology there as well. We know that a lot of people already had a CDI program before ICD-10, but a lot of people were really trying to ramp up their CDI. So think about what has happened with your CDI program in your facility. And I don't mean just hospitals. I mean CDI should really be, clinical documentation improvement should be in the physician practice, the clinics, outpatient, inpatient. It really should be across the board, because we always can do a better job of assisting our physicians in making sure the documentation is there. I have one of my clients, they have a nurse that actually goes in, she works for the physician, for the surgeon, and it's her job to go in and review the records and make sure that everything is there that is documented appropriately so that the doctor can get paid appropriately and that the documentation matches what actually happened with the patient. They don't call it CDI, but it really is CDI. They're doing clinical documentation improvement while the patient's still there. They're going out on the floor and helping the physician. I love to see that kind of a change in thought process from our physician groups as well. I'm actually seeing a lot more scribes being used. I don't know how you guys have seen that, or what's going on in your facility or with your doctors, but I'm seeing more scribes being used, like in the emergency department, where they help assisting the doctors in being able to get the documentation there that's appropriate. And remember that CDI, we need to have some CDI going on at pre-discharge before the patient goes home. We need to be reviewing the documentation, and you need to have a good query program. We're going to talk more about query program in a little bit. We also have been looking at streamlining our documentation workflow. Hopefully you've been reviewing automated tools. There's some good query software out there, any kind of electronic documentation. I know a lot of you already had the EHR in place. Sometimes that's good, sometimes not so good. And a lot of our doctors are very frustrated with the EHR. And also a tool such as computer-assisted coding. At TruCode, we've seen a lot of increase in people going with CAC. So we know that because we have a lot of our, I think there's 6 leading CAC tools that have TruCode embedded within their products, and we're seeing an increase in the number of facilities that are using computer-assisted coding to try and make the productivity better. And so that's exciting as well, to use that technology to make our jobs a little better. So those are all a lot of things that we looked at that we knew were going to impact the claims, and again still today that can make a difference in productivity. So we also talked about steps taken to reduce the impact of decreased productivity, and one of the things we talked about was taking an inventory of our coding professionals' knowledge base, and part of that assessment to really think about what we wanted to do with new materials. Hopefully everyone, I guess it's been a year now, the people that are working in your practices or in your hospitals, they are, you know, all trained in ICD-10, feel very comfortable in ICD-10, and we knew that a lot of the way to get ahead was to eliminate a lot of the coding backlogs prior to ICD-10 implementation. So remember that productivity not only involves coding, but it also is other areas as well. So as we're going through this today, I'm primarily focusing on the coding profession, CDI, documentation, that area. But remember, anywhere that is, any area that's using codes, you need to look at their productivity as well. Because if they're slowed down in other areas, that could mean that the whole process, the whole revenue cycle, the whole entire cycle of all of it can be impacted. So it's not just the coding staff, it can be your case management, your clinical documentation improvement, HIM, health information management, your claims processing, especially with the electronic billing system, collections and decision support, all of those who use codes. I have actually seen a couple of clients who did not train their coders in ICD-10 PCS on the outpatient side because their decision support or their internal EHR just didn't provide really good reports for a CPT, that they have actually gone back and are now coding ICD-10 PCS for outpatients. I don't like to see that happen because I think that there's really a lack of documentation on the outpatient side that's really not there to really reflect the level of specificity needed for ICD-10 PCS. So I hope that that's not going to be widespread. Just heard of a couple of facilities that has happened to, and that's going to slow down your productivity if you're having to use ICD-10 PCS on outpatients, unless you've done really good education and the doctors are really doing a good job. And many times it can be the level of your ability to be able to change or to modify your EHR to make sure that you are able to get the information there and change the information to be able to get that data, good data in there. So that's productivity, again, not just the coding area, all these areas can be impacted as well. Also, we knew, and this is still an issue, the implementation variables. We knew that that was going to impact productivity, the amount and level of preparation. I have one physician that said that they were not going to learn ICD-10, they were just going to take the fines. And so we had to tell them, well, if you take the fines, that basically means you're not going to get paid because nobody's going to pay you on ICD-9 codes anymore. It's not just like a penalty. It's like you won't get paid. And they said, oh, well, I guess we have to learn this. And the doctor was, you know, he was getting ready to retire, so he didn't really want to go through that. So that was a big issue there. I've seen as well, not as much on the hospital side, but on the physician side, there's a lot of variety and variabilities on who's actually assigning the codes. In some of our clinics, we see that the doctors are assigning their codes, and they're trying to code from a pick list instead of using the code books the whole way through, going through the alphabetic index to get the most likely code, looking at all the notes and the rules and using the official coding guidelines. They're still trying to just code it themselves like they've always done it and trying to change that. So we're going to talk about physicians in a little bit as well. So I think that's another big issue. I did a class just 2 weeks ago, and it was on for physician practices, and I was talking about official coding guidelines, and I had people there that had never heard of official coding guidelines. And so again, you know, I think if those of you from the hospital side, you know, that's something that you've been following for years, but there's just a variety of levels of how people have been educated and trained when they're using coding. And so we want to make sure that we're looking at that. We also know that the implementation changed depending on the extent of the education and also credentials. I've seen a lot more people that have gone back and they've gotten their credentials. They feel like that helps them. And also when you're looking at job descriptions, a lot of facilities have added in, if it wasn't already there, they added in, you know, we really need people to be credentialed and certified in coding. And there's a couple organizations out there that can help you with that. And so again, that's a good deal as well. We also know that some of the productivity is based on individual code assignment experience. If I never do interventional radiology, I'm not going to be a very good interventional radiology coder. And so we need to make sure that you have education, and it may need to be specified, very specific for certain areas. We're going to talk about that in just a little bit. I know that knowledge of anatomy and disease processes, that was something that we tried to really work on before we made the transition over, and that's still an issue. you still need to have good references to make sure that we can look up things and that we have the time in our schedules to be able to look stuff up. I think that as a lot of you, now that it's been a year, you're looking at your productivity data and you may be back up to where you were before, but you also want to make sure that you have those numbers are high enough to get the jobs done, but they're not so high that people are discouraged really from doing more education and research. Sometimes, you know, the more that you can look things up and have that freedom to be able to go, yeah, I'm not really sure on this, I need to go check this out, that's going to make people better coders in the long run. So we need to make sure that even though we're going, okay, we're a year, we should be all happy and all better, not necessarily. We got to make sure that we're still looking at training and education and new procedures and doing in-services with our physicians and our coding professionals and our CDI people. So again, we're going to talk more about that. Quality of medical record documentation. That is something that I could have put on a slide 20 years ago, and it's just as appropriate today, because we know there's still, in some areas, there's still not going to be good quality documentation, and you can have the best trained coding professionals in the world, and if the documentation is not there to support it, it's still going to slow us down. And we've got to make sure that that has been not only with our coders, that they understand that, but also the powers that be understand that as well, is that if we, you know, we've got to have a good backup to be able to look at the good quality of medical record documentation, that we expect that from our clinicians, and that there's a way to monitor that, because it's not going to be pretty without that. And then of course we know that organizational size and complexity, if you're working in a one-person family practice clinic, or a multi-specialty clinic, or a big hospital, or a level 1 trauma center, you know, the ones that are, you've got the bigger areas, you have more choices, more codes, because you got more complex problems and more variety of problems. Those are all issues that even to this day are still having impact on our productivity. So I know that we've talked about this before, but I just want to bring these up again to make sure that we're still looking at these things and going, you know, when's the last time we looked at that? How are we doing with this? Where are we taking into account those different variables? You know, if you've got a new coder, where did they come from? They may have done great on your test, but then you've got some new areas. Maybe they're struggling with that. Okay, so let's go into what can we do now. And again, some of the things I think we've talked about are not just old, they're here as well. So I think that's one of the first things to talk about now is, what are your areas of struggle? And we know that some areas are fine. You know, documentation's there. Fortunately, doctors are putting things like left and rights and things like that. And you may have some areas, let me go back, sorry. We may have some areas where there's no problem, that we thought there'd be a problem, but there's not. I think now with the since the official coding guidelines were updated and the codes have been updated as of October 1st of this year, we did get some good codes that we were lacking. Like, I'm really excited to have gotten the code for the hypertensive crisis, hypertensive emergency. We've been lacking that code for years. We've needed that. And so we've got some new things, and also some clarity in the guidelines that, you know, again, they've been changing the guidelines every year, but we had the coding freeze for 4 years, and so we weren't able to add those new codes. And so again, we may have some struggle now, because now we have over 2,000 new ICD 10CM codes and over 4,000 PCS codes. Again, even though that's a lot, I haven't seen a lot of difficulty with that, because they were ones that we've been waiting on. So we got some really good areas there. Plus, some of the official coding guidelines, they actually solve some of our problems. Like for example, with our patients who have open fractures, open traumatic fractures, where it's got, you know, open Gestalt classification 1, 2, and 3. Well, if the doctor didn't tell us what the Gestalt classification was, we had no default. There was nothing that says, if the doctor just says open and doesn't say what of these it is, then use this. They didn't give us that. So now they have that. Now in the official guidelines, which do take effect on October 1st, they said that. They said if the doctor says open, but he or she does not say if it's a level 1, 2, or 3, use the lowest level. So we've got good guidance, and so we want to make sure that we've discussed those new guidelines with our coding professionals and talked about those, and talked about how those are going to make our lives easier, better, or just give us more clarity. And they clarified things like bilateral. What do I do if the patient comes in with bilateral cataracts? And they only treat one. Do I code the left side if they're only treating the left side, even though technically they have bilateral? So they've addressed that. And so again, I think knowing those coding guidelines and watching for those changes, very, very important. And I think that's also true with our coding clinics because those are quarterly and we're busy. And so we need to make sure that every quarter that we stop and have a timeout and talk about those official coding guidelines and how those are the new coding clinics, because sometimes they change their mind. That's one of the areas where, you know, when I was starting to teach ICD-10, we taught by the guidelines. We taught by the coding clinics. And there was one case where I found where I read in coding clinic and it said how to code something, and I thought, well, I don't know that I would have done that before it said that, but that, you know, we go, that's the rule. If it says that, that's the rule. And so I started teaching it the way it said. Well, then the next quarter they came back and said, you know what, we kind of screwed that up. We messed that up, and so we are changing our opinion. So because ICD-10 PCS has been so new for everybody, until someone came up and said, hey, that didn't sound right, then we just went with that. So even though those are still great, and I still do strongly recommend that you watch those very carefully, if there's areas where you don't feel like they're right, ask about that. Question that. Say, is that true? Is that really what we're going to do? And we're going to talk more about that in just a little bit. So we want to have a realistic discussion of our weak spots. How are we doing? You need to have audits, and I don't necessarily know that you have to have external audits, but we need to use audits as really not as grades as far. We really don't want to see them as punitive. We want to see them as educational. We need to have those audits because we need to make sure we're doing good. We don't know. We think we're doing good, but maybe there's an area that we weren't as comfortable with, and we thought we were doing it right, but actually we weren't. Or we weren't doing it like everyone else, and so now we have to go back and go, okay, do we need a policy that covers this for everybody? So we really need to think about those. And again, now that we're a year into it, I think we've got a little bit of a time to take a breath and go, okay, what's really going on here, and seeing how we're doing. And again, it should be approached by everyone as this is not punitive, as I mentioned. This is to help us all to do good. And then we have those discussions of those weak spots, and maybe we change what some of our coding professionals are coding based on that to put them in areas where maybe they're more comfortable, or we provide more education in those areas where they're not doing as good. They may still be a great coder, but this is just not their best point, and so we either help them fix it or we move them to another area. And so we need to have those realistic discussions. And from coding professionals out there, that's something that you need to be aware of as too, and to be honest about that. It's like, you know, I feel like this area is just not my best and I need some help. And our facilities need to be there to help us do better with that and to give us the tools that we need to be able to get better. So those areas of struggle, I think, is a big deal right now that we've been into this for a year. New codes. We did get, as I mentioned, a bunch of new codes this year. And so one of the things that I think we need to think about from productivity is this, is that just because we have new codes doesn't mean you always have to use them. You need to think about them and come up with possibly a policy on those. And one of those I pulled out was the stroke scale. So we have these new stroke scales, and basically they are used by the clinician to show how bad the stroke is. And you can do this anytime you want to. They can do a stroke scale in the ambulance. They can do it in the emergency department. They can do it when they first are admitted to the hospital. They can do it 24 hours after admission, and so on and so on and so on. Does that help? Does that change anything? If we're a research facility and they're really doing a lot of research on strokes, and this is something that's really critical, absolutely, by all means, use them every time you need to. But other than that, do we really need those? You know, they're great. So, and again, they tell information, so it's wonderful. If it's documented, we need to code them. Now, in the official coding guidelines, when they put these codes out there, I've got this quoted here because it's out of the official coding guidelines. It says they can be used with stroke codes, and at a minimum, you would want to report the initial score documented, and if desired, a facility may choose to capture multiple stroke scale codes. So my point here again is just because there are new codes doesn't mean you have to use them. Are they helping? Are they benefiting? Are they telling the patient's story? If so, then by all means use them. But if not, then maybe we don't need to. Or maybe we don't need to use them every single moment they say them. Some doctors might say every time they go in to see the doctor, they may give you a stroke scale. Again, you might want to have a thought process there and a discussion of what is appropriate, how should we be coding those. So always something to think about with any new codes. And we're about to have new CPT codes coming up in January for those of you on the outpatient side. So that's something else that you might want to think about as too. And what about secondary codes? Secondary codes, procedures. So again, you want to make sure that you are coding all secondary codes that do impact the care. You want to use the guidelines in the official coding guidelines that talk about when you should code secondary codes, and basically it says something about the fact that, you know, when they impact the care, if you had to do any diagnostic or therapeutic, if they increase the length of stay, those kinds of things. Use that as your guidance for when you're going to use secondary codes. And remember that a lot of reimbursement appears to be changing to where it's going to be more quality-based and looking at outcome of care and looking at severity of illness. And without those secondary codes, then we won't have a good picture of what's going on in the patient. So let me clarify, I'm not by any means saying don't code any secondary codes. That is not what I mean there. But I'm thinking about things like external cause codes. Certainly, if the patient comes in with a trauma, we definitely want to code the external cause code if known. What about place of occurrence? Is that helpful? If it is, great, but I have some of my clients that are saying, you know, we don't have time to code those. It's not, you know, so they have certain policies and rules about when they code those and when they don't, if it's a workman's comp, for example. So just think about that. And again, I'm not saying you don't want to do that. I'm just saying at this point we need to realistically look at what we're doing and try to figure out if this is the best from a productivity standpoint. Is this really accounting for or doing what we want it to do? I have some facilities that are not coding transfusions anymore in ICD-10 PCS. They may be coding it in CPT. They may be capturing it somehow someplace else in the facility, but some of them are saying the coders are not going to code transfusions anymore. Again, that's totally depends on what you're using them for. I'm not saying that's right or that's wrong. I'm just telling you these are things that we're seeing people and facilities making decisions on because they're looking to make sure that productivity is there where you need to be. If you have any procedures that are already captured by the charge master or charge description master, CDM, even some of our radiology and other types of codes, even when the patient's on an inpatient side, we need to look at how and what we're actually coding. So those are things that you want to think about to maximize or enhance your productivity there. Let's talk about denials for a little bit. As I mentioned earlier, that was one of the areas that we've talked about for a long time when we've discussed about, you know, documentation. And we have found that there is sometimes a need for better documentation to fight those denials. We have seen with ICD-10 that denials have been more about specifics, and I'll give you an example of that. Had a physician who had a patient coming in for migraines, and they were getting shots, and the doctor was using just a plain old migraine code, no auras, no nothing else. He was just using a plain old migraine code, and he got a notice from the insurance company that said that they were not going to code it because it was not a specific enough code. His first question to me when he called me was, can I just put X's on the end of this code because it says it's not specific enough, and you told us sometimes there's codes that are 7 characters long. I said, no, that's not what you want to do. We want to think about exactly what it is they're telling you. And remember, when he was using that plain old code for migraine, when you look at that code, that just says, I had a migraine today. It doesn't say, I'm having migraines every day. It doesn't say, if I don't have this medicine, my migraines are out of control. It doesn't say that. It just says migraine. So we need to really look and see what is the code saying. It's just the same as asthma. Yes, there is a code for just plain old asthma, but if that patient's in the emergency department and the medicines are not working and it's acute attack, then asthma is not specific enough. It's not enough detail there. And we're starting to see more insurance companies, especially now that year, remember with physicians, Medicare gave them a year to get used to ICD-10 before they started penalizing them. That year is now up. And so you've got doctors that may have been coding the very minimal stuff out there, and now they're seeing that that's not something that they should have done. Remember that whenever you have anything new, typically you got 2 years of data, and that data that's being accounted for or captured right now is going to be used to make up new policies probably about this time next year. If people didn't code correctly for that first year, we've wasted a whole year of coding. We've got a lot of data in non-specific codes that are not going to tell the severity of illness for our patients. So we need to be looking at that. Again, if you're in coding, you may not be the one that looks at the denials. We need to make sure that they're looking at denials in our facilities and they're checking those and make sure that we have the details necessary to show exactly what it is we did for the patient. Again, that's the whole thing about ICD-10, is that it is so much more specific. We should be able to get a lot better detail about what's going on with that patient to be able to justify what we did to treat them and to be able to show why these patients, it took more to treat them than the ones over here. And again, when you start looking at HCCs, those hierarchical condition codes, and when they're looking at blending and bundling our payments, that's all coming from these codes. And so we got to make sure that everybody who's using the codes understands what kind of damage that can do. So with that, we may need responses from those with chart knowledge for looking at things like medical necessity and specificity in code. So I think that's you're gonna see this more. I'm starting to see this creep up a little bit. We need to make sure we're watching those. So we need to make sure that we are tracing and fixing those issues. What are the issues causing denials, and how are we fixing those? We need to look at the communications between business office, HIM, coding people. We need to look at those current denials, where we are in the process of management of those denials, making sure we're effectively managing. If the codes are changed, who changes those codes? If the documentation is amended, how does that happen in the facility? We need to make sure this is part of the whole, again, can be a productivity and can be a reimbursement issue as well when this is not going well. We also need to think about our process, and that's something that I always talk about when I'm teaching coding these days, is because we need to think about how our process is working. And just because it's worked for years or it seems to be okay, we need to see, is this really the best process to move us forward into the future? Looking for things like bottlenecks, poorly managed handoffs, workflow issues, when we're waiting on another department or another area, when we don't have the documentation we need from the doctor and we have to wait for them, and then they have 30 days to get that information back to us, and we can't bill until then. Those are the kind of things that we need to look at and see, is this really the best way to handle it? We need to make sure we're tracking and trending those denials, that you have good tracking metrics to help your organization better identify those denials, looking at trends by payers, by procedure, by diagnostic code, categorize those, identify payment barriers, all those kind of things that should have been happening all along. We want to make sure, definitely now that we're a year into ICD-10, that these kinds of things have been happening and that they're working well, because that's the only way we can see. I have a lot of physicians that tell me, well, I don't know how I'm doing, nobody ever tells me, or they say, well, I want to know how I look in comparison to somebody else. So we need to, make sure that we're providing education to our physicians. A lot of physicians really don't know. They're not trained on coding in medical school. I had some training not long ago when I was talking to some physicians who were educating new physicians, residents, and medical students. And we had some discussions about their terminology and how we interpret it, like history of. When a patient comes in with an existing condition, the doctors were trained to say the patient presents with a history of whatever. And I said, okay, what that means to us, when you say history of it, means it no longer exists. And the doctor said, no, when we say that, we mean it's something that is there when they come to us. It's not a new thing. It's here's what they're coming in with. So we talked about maybe some changes in the lingo. Instead of saying history of, just saying the patient presents with a 5-day for 5 days they've had this problem. But again, we're trying to use that word history again. When you say history to us, we don't code it, or we code it as a history of something, and we don't always, that's not always what they mean. And also we had a conversation about complications. And basically, if the patient has something post-operatively, they're thinking time frame. After the patient had surgery, this happens, so they say in the post-operative period, these happens. So we're trying to figure out, is that a post-operative complication or not? And then we have a new guideline this year that talks about that. So those are the kind of things that we need to have communication, because what the doctor thinks they mean and what we think they mean may not be the same thing. So we need to have communication, and teamwork effort throughout all of this is critical. Nothing new, but still something that we need to really focus on in this new era of ICD-10. So as we talk about our physicians in your network, we've talked about that a little bit. We do know that a lot of the clinics do have practice management systems. Sometimes they have their own EHRs. Sometimes they don't love them. Sometimes they have been bought by the facility, and so they're sharing the EHR, and so they have access to everything. I have some physicians that are on medical staffs of 3 different hospitals, and they have their own EHR within their practice, and the EHR is making them crazy because they're all different and they can't find things. And so again, that's one of the areas there, that their management systems may or may not link in with yours, and they may not have access to all the data that they need. Also, remember, some physician offices don't employ coders. As I mentioned, some of them they're trying to code from a stick drive, that has all the codes, or a list of codes, and they're missing the whole point of, and the whole way that the ICD-10 system was set up was basically as a classification system to group like diagnoses, and without having all 3 pieces, the alphabetic index, the tabular list with all the rules, and the official coding guidelines, they're going to make mistakes in the codes, and I see that happen all the time there. So if you're in the hospital and you are helping the physicians, making sure they understand that and helping them with that area as well, and helping them understand that basically having a list of codes is going to make them more frustrated, and so it's going to cause them to be less productive, and then you're not going to get what you need on your side either. If you work for a physician practice, that's the other thing too, is looking at your process there to help them. I would rather see our physicians, whether they're hospital-based internal medicine guys, or the hospitalists, I'd rather see them spend their time on taking care of the patients and documenting well, and then at the back end, the coders or the CDI people in the middle can help them make sure that the codes are there. When our doctors are trying to do all the coding, they're very frustrated with it, and that's why, because they're trying to use it a way that the system was not really designed. So we're seeing coding errors. As I was just talking about a while ago, the doctor wanted to add in X's at the end of the codes and thought that that would be real helpful, and that was not really what he needed to do. So we had to kind of backtrack and re-educate on that. If you're using any vendors or any outsourced companies, that sometimes people have used that as a way to be able to make sure that their productivity did not go down. But who's watching them? Again, what are they doing for you? Are they coding the inpatient side? Are you coding the inpatient side and they're working on the outpatient? Again, we want to make sure that we're checking those, that we're verifying. If they have a quality assurance area, which hopefully they do, then we want to make sure that we can see their data. What happens with these patients? How often are they auditing their work? And what is the results? Are they following the same policies and procedures that we use in the hospital? So you want to make sure that they have received the necessary education and that they are having ongoing training with ICD-10. And again, you should ask for documentation. Who's actually doing their training? Has it been provided by a qualified trainer? And there's a lot of different ways you can find that out, but that's something that should be part of your contract with them, that we're checking to make sure they're doing it correctly. Another area is waiting for guidance, and this is something I mentioned a little bit earlier today, but this is something that we talked about, we've been talking about for a while, as far as what happens if you go, okay, I'm waiting for guidance. I know there's a problem with PCS. We've identified this problem. We have sent a question out to the Office on Coding at the AHA, and so we're trying to wait for that. What do we do in the meantime? If there's nothing in Coding Clinic, if there's nothing in the official coding guidelines, what do? What you want to make sure is whenever you address those, whenever you find those issues that are problematic, if you're waiting for help, if there's nothing anywhere else as far as official coding clinic guidelines, those kinds of things, then you need to develop internal policies. You need to at least make sure that in your facility or in your clinic, you're all doing it the same way, because otherwise that's going to cause a sense of a slowdown, of basically of not having the the productivity can slow down because we're going, okay, what do we do again? I remember we had this come up a couple of weeks ago, and I don't remember. Did we ever decide what we're going to do on that? So come up with policies. So that's something that would be helpful too, and you should have input from your coding professionals on that. And so that's something that I think is real important, that we do have some kind of a, until we get something official, until they come out with something in Coding Clinic, we're going to do it this way. Now, that also helps you because then if it's official at some point and you change it, then you have something to back up. You say, okay, we have a policy because there was nothing else. And so you keep those and you show what policies you are following at that point in time. I think that's something else that has slowed a lot of people down, and it's been real frustrating because we've been waiting for that guidance on certain areas there. Okay. Also, something I've mentioned that does impact productivity is the electronic health record. Sometimes from a coding professional, it's hard to find things. You know, that they may have tabs here and tabs there. Sometimes the physician doesn't know which tab to look in. And then I have doctors that copy and paste. They're copying and pasting everything because I think that's helpful. Sometimes they really do think it's helpful. And so we need to make sure we're having education with our clinicians about what's appropriate to copy and paste, when should we do that, and when should we not. I've seen tons of productivity issues because, especially if you're in a teaching facility where everybody wants to copy and paste, and then you end up with this record that was 1 page and now it's 20 pages, just one thing. And then again, the record becomes huge because people are copying and pasting everywhere. I think we've been talking about this for a while, so I'm hoping it's better at your facilities, but we need to make sure that we're having that ongoing education with our clinicians. I know that I was in one facility teaching on ICD-10 to the doctors, and I talked about copying and pasting, and one of the physicians got really upset, and he said, we're taught from a legal standpoint that we need to copy and paste like all the x-ray reports because then that shows that we've read it. Well, we can see the x-ray report. We can click on the tab for x-ray and see the report, so it really doesn't give you more information. You can summarize, or you can say, I looked at the report and I found and I agree with, or whatever, but really copying and pasting the whole entire information is not always helpful. We also see sometimes that they'll copy and paste only pieces of it, and so we'll have a patient who will have gallbladder issues, and all of a sudden there's a head x-ray in there, an MRI of the brain, and you're going, where did this come from? I can't even tell if it's the same person or not. We had one physician who he accidentally, and this was an ER physician, he accidentally copy and pasted, his son had texted him at work and said, Dad, there's this really cool video on skiing or something, and so he was watching that while he was waiting for the next patient, and then he copied it, somehow he accidentally copied it and accidentally pasted that video in the patient's record. Not on purpose, of course, but there it was. So, you know, there's a lot of issues with that. You need to make sure you're having those conversations with your clinicians because it's slowing down your coders. And so we, again, sometimes we can't tell who does a procedure. Another thing we found is sometimes when they do procedures, they say procedure performed by, and then the drop-down box, one of it is self, procedure performed by self. Well, what if you copy it and paste it from here, you did it, and you copy it over there, or somebody else copies it. Now it looks like maybe they did it again. So now I'm going to build that again. I'm going to code that again. You can see how that can really cause a lot of issues, and then you may get into some fraud and abuse issues because things are overbilled because the copying and pasting. So I think it's real important. I've seen a lot of times too where we have a group full of, a room full of clinicians, and I'll be talking to them about things they can do in the EHR, and then one of the doctors will say, well, we can't do that here. And one of the other doctors says, oh yeah, all you have to do is this. And so it may have been a while since they've had education on your EHR, and we need to make sure that we're refreshing those, because you know how it is, we get busy, and things that I don't do every day, I forget about. It goes out of my brain. And so we want to make sure that we're providing ongoing education and training on different tips and tricks in the EHR for our physicians. Again, especially thinking about the fact that they may have multiple EHRs they have to work out, and they want to do it right. We just got to help them, give them the tools to do that here. As I've talked about all day today, we've talked about documentation. We know that's a major issue. You need to continue to work with your physicians to identify areas of opportunity, and you need to have reports on your findings and talk about those findings and how are we doing. You need to have your physicians in every area. You need to have a champion in those areas to help you be able to address those issues with your physicians. A couple of the slides here, we're talking about documentation readiness, and these a couple of slides here are things that have hopefully been done, because this is when we were talking about getting ready. So I just wanted to give these to you so you can look back and say, are we doing these? We did those maybe before ICD-10, but maybe it's time to go back and do that again. Those focused documentation audits by specialty, looking for patterns, looking for missing or incomplete information, making sure we're training based on our new needs. We may have found that something we trained on last year is good. They're doing great with that. Make sure to let them know, hey guys, you've done a wonderful job with this area. We are so proud of you and we thank you very much. But here's a new area. You know, always use that sandwich technique. Tell them something, you know, we got to change something, put the good at the beginning, tell them what they need to change, tell them good at the end. You know, you want to sandwich the bad stuff in the middle. But again, we're always learning, and sometimes it's good to see the same thing over and over again. You're just expanding on it. You're talking about what we found out now. So you want to make sure that we're going with that. Remember that with our CDI and our inpatient coding professionals, remember that doctors are still paid based on CPT codes. So that's still an issue, is that they're not paid based on all the extra information that you may need with ICD-10 PCS. So we need to remember that, and when we're trying to get their information there. We've talked a lot in the past about gap analysis. Now, back when we first started talking about this, gap analysis was, what do we got here? What are we coding and documenting in ICD-9? And what are we going to need in ICD-10? But you can talk about gap analysis even now. A gap analysis basically says, what have I got and what do I need? So you can still do gap analysis to see where you are missing. What's the gap between what we need to have and what we just don't have yet? So again, hopefully there's been some areas you've taken care of that are weeded out, and now we're really focusing in on those areas that we can continue to make headlines with and make sure that, we're going in the right direction with those. I put a couple of slides in here about clinical documentation improvement programs. I still have some of my facilities that are still trying to evaluate their CDIs and making sure that they have the right people in their CDI programs. So just a little bit of information about that. You have this in your handout. I'm not going to go all through that today, but I just wanted to have that there. We need to continue to assess those CDI practices, looking at the documentation, making sure we're implementing and monitoring our improvement strategies. We're continuing to collaborate with your physicians, continuing to provide training on CDI to those providers, and then again, any vendor-supported CDI tools can assist us in making sure that we're at the right level that we need to be. So we had some, you know, CDI that was working out there. We were kind of getting this. One doctor said, we're getting the low-hanging fruit. We need to be moving up the tree a little bit and getting up to the higher levels, the things that are really going to make a difference there. Okay. All right, so again, a couple things with gap analysis. We've talked about those before. I just wanted you to have those in your handouts in case you still need to be looking at some of those areas. But basically, I think we've covered those for today. We need to really be looking at query, and there's been a couple of increased or new publications coming out from AHIMA on the query process. So I just have you in here a definition of query, and I think queries are important not just in the hospital setting and not just on the inpatient side, but I think we need to have a good query process in our outpatient area as well as in our physician practices. There needs to be a good way. If we have an issue, how do we go about getting it resolved, and what's our expectations back from the physicians? So again, I just wanted to make sure when we say query, you know, question, even in the official coding guidelines, many times it says exactly what we need to be doing and when we can ask a query in first. So now, after we've been doing this for a year, thinking about your query forms, and I know many of you that's an electronic form, but after we've been doing this for a year, how are your query forms working? What is your percentage when you're looking at the number of queries sent versus the number you get back? Now remember, you have different statistics here. I want to look at the number of queries we send out and then compare them to how many answers we get. Now notice I did not say how many positive answers, because sometimes the doctor says, nope, I don't need to change it, or no, I don't have any more information, I'm not going to do that. So that's very different. We're looking at how many are responded to And then you can look at how many responded to positively. Because again, remember, the doctor is still in charge of they're still the captain of the ship. They're still the ones that say yes or no based on what they clinically feel is important with that patient. So we just want to make sure they're answering us. If the answer is no, that's still an answer. So when you're looking at your metrics for queries and our percentage of queries that we're doing and how many we're getting back, think about it from that perspective as well. So here it just says from the AHIMA Standards of Ethical Coding, you want to query the provider for clarification and additional documentation prior to code assignment when there's conflicting, incomplete, or ambiguous information in the health record regarding a significant reportable condition or procedure or other reportable data element dependent on the health record documentation. So present on admission, that's another thing too. That's part of our queries that you should be doing. Remember that queries are not to question diagnosing or treating the patient. It's to clarify documentation. So you might want to have a discussion with your physicians that they understand the purpose of the query, and it's not just that we're trying to badger them or trying to, and I've had doctors tell us, oh yeah, the hospital's trying to get more money. We know that's not what's happening. We're trying to get appropriate reimbursement. But we need to make sure doctors they're not always told these things. They get these things, but they don't always understand why they're getting those. And so you might want to have discussions with them, and that can help their camaraderie. That can help them feel like they're part of the team instead of that we're just bugging them. I think we've done a good job with that, but I just wanted to stop and have you think about it from your facility or your practice, and are they working? Are you querying more? What are we querying for? What are our statistics? And then be able to provide that back to our physicians. Remember, in our surgical issues, that is probably the biggest area because of ICD-10 PCS. They're not going to change their procedural language, and again, we need to make sure we're interpreting and following the rules of ICD-10, again, especially PCS. Part of the surgical issue is that our clinical documentation coders or specialists need to have to read the operative reports more closely. That may mean that our productivity is down on the surgery side because we need to find more information. You know, does the doctor say when there's those like the hip replacements, when it says cemented or not cemented? You know, is the doctor saying that? Are we having to search for it? Where is it in the medical record? And sometimes we can have discussions with the people in charge of our electronic health record and get some of that information added in to, like some of our hospitals have like a short, like a summary of the operative report, and sometimes they're putting those kind of data elements in those reports that make it a little easier for our clinicians and then our coders to be able to find the information they need. Another thing I put in here is that some hospitals are having them review surgery schedules prior to the date of surgery, and then we know what necessary items have to be documented. We can talk to the doctors about, hey, I noticed you're doing a hip replacement and we need to make sure these are the things we need to document, that we need to make sure are documented there. So there's various different ways that you can do that. But when you're having these discussions with our doctors or the surgery areas and getting the information you need, that is going to improve your productivity as we're going through. All right, documentation, as I mentioned, I think documentation is probably always going to be one of our biggest areas. Again, one of the biggest productivity with all of this is that if the documentation is incomplete or if there are very difficult procedures, then that's going to slow down our coding, because we don't have, you know, we've got to take longer in that medical record going through those difficult procedures, and then we have to stop and send a query and then come back from there. So again, you've got some issues there as we have been discussing about how this is impacting your productivity. Also, because of the specificity required, especially in ICD-10 PCS, it's requiring us to take what you call a deeper dive. We're having to do more reading, more deciphering, having more discussion with our QA person, with our CDI person, and when this is happening, that is definitely causing an increase in our productivity going down a little bit. So if you have new procedures, anything we can do to get that comfort level in our coding. And one of the things is, like I said here, we don't always trust ourselves. It's new to us. You know, we hope that we're doing it correctly, but we really want to talk about it more because we don't know. And this may be more difficult for those of you who have off-site coders, where people are coding from home, coding remotely, because they don't have anybody out there to ask there. So it's not like they can just stand up to the cubicle next to them and go, hey, Joni, can you help me with this? And so what is your process for your off-site coders if they have a question? And do they get a response back quickly? You know, is there someone that they can send a response or a question to and it gets right back to them? What's your process on making sure that they have the tools and the assistance that they need so they don't feel like they're out there on an island far away from everybody? You know, some people do really, really good coding remotely and other ones don't always do as good with that. So those are things that I think are helpful to think about, because that can definitely make a difference in productivity. Your CDI can help with this. They can do the deeper dive if they know what is needed. They can also educate the physicians, and then they can team up with the coding professionals, and so we can all learn from each other. We also recommend that you do have a discussion of your documentation issues. Have regular meetings, if not with the physicians, at least with your CDI and coding professionals, that you have regular meetings and talk about some of the issues that have come up. Again, we can learn from each other. Physicians, get them involved as well. Talking about your ongoing issues, you might want to pick a topic of concern. You might have your physician come in and explain procedures that are difficult. They can see what you need, you see what they need, and that's very helpful. The coders can then talk about the documentation issues, and as I like with this is everybody learns. They see it from both sides. They'll go, oh, I didn't know you need that, or oh, I thought you were getting that in CDI, oh, I thought the coders got that. So having those regular discussions really is going to assist you with us all being more of a team and understanding what's going on and being able to help each other be able to do a better job. And again, that should increase our productivity. And one of the last things I have here is just using references. I think that you have to have good references, and you have to have time built into your productivity schedule to make sure that people are in, they should be oh, I'm trying to think of a good word for this, but you should, instead of saying, oh, well, you've got to get all your records done, which of course is very, very important, that we do encourage them to use their references. And if they don't know what something is, use it, look it up. So making sure we have references, our coding clinic, our official coding guidelines, you have a medical dictionary available to you, the AHA coding workbook, which used to be called the Faye Brown book, that's something there. All your clinical references, like in TruCode we have Clin Notes, which is something we actually added this past year because a lot of our clients said, hey, we're using this a lot more with your CDI people, and they want to have a clinical reference such as Clin Notes to be able to give them all the clinical information, the etiology and what are the common diagnoses and procedures and the lab test I would expect to see with these. Don't forget to use a PCS. You have your PCS appendices, the body parts key, the definitions key, as well as your PCS reference manual. You should have all those references easily accessible for your coding professionals and your CDI professionals to be able to go through there. All right, last thing we have today, we've got about 5 minutes left in our presentation, and I just found this, and I've talked about this in some of our other classes, but I just wanted to remind that that some people are choosing a different route in assigning PCS because we know that that is biggest concern. We don't have as much guidance. It's really different from anything, and we're always looking for something we can do to be more productive. Now remember that in the official coding guidelines it does say that you do not have to use the alphabetic index, and so if you feel comfortable in knowing what those definitions are, you can code directly from the table. So this just shows you, and I'm just showing you in TruCode, basically you start off with, you go to, you can see here I just put in a 0 to open up the procedure tabular in PCS, and then you just go through the table. Now again, the premise of this is you have to have a good understanding of PCS. You need to make sure that you understand and are very clear on the definitions there. So as I go through, you see I would pick out the section, mostly it's the medical and surgical section, and then I'd go to body system and pick up the body system there. From there I would go into, I would go to the body system, and then I would pick out the operation. Again, this is where if I'm not sure on some of these definitions, I need to make sure that I'm using my guidelines, using my official coding guidelines and coding clinic articles and those kinds of things. I chose extirpation because that is everybody's favorite definition, root operation there, and so that's very important. So if the doctor says that they did a TURP, a transurethral resection of the prostate, then the coder's got to be comfortable enough to go, yeah, but it's not really a resection, it's an excision. So we got to make sure that we feel very comfortable when we're doing this. Once we pick out the right operation, that's the big part. That's going to take you to the table, you basically to the real table there, and then you pick out the specific body part. Hopefully the documentation shows you there. And then from the specific body part, you pick out the approach, again, knowing your definitions there, and then from there you would follow your row across, and whether there's no device or there is a device, and then the qualifier to get a fully functioning 7-character code. So it's just really something that I think is important to talk about maybe there's another way. People that do this and feel comfortable with this, they feel like that does make them more productive in coding ICD-10 PCS. So I wanted to just kind of throw that out there to you as one other way that it might be able to help your productivity. Lastly, I think communication. I've talked about that throughout this hour we've been on the call today. Communication, continued ongoing communication, making sure you're still building awareness, making sure we're looking at those areas that it's not something that, oh, we did it last year, it's all gone, it's done, it's ongoing. And we got to keep learning, we got to keep thinking about and looking at those changes in our coding guidelines and our coding conventions. We need to continue to identify your at-risk services, continue education with your physicians. Again, we know that there's, even with our new codes this year, we saw that there's increased need for specificity, especially in the cardiovascular area with ICD-10 PCS. So again, it's not just something we did before we made the transition last year, it's something that's ongoing. Continuing to evaluate our query process, continue to evaluate our tools that can assist with productivity. Again, we've talked today about CAC, computer assisted coding, and also CDI tools as well, and then the importance of education. Educate, educate, educate. So those are the things that I think are very important to help with your productivity. We also have and I don't have it here with you, but we will send it out if we haven't done that already. We have a little metrics thing that's got a little, I think there's 8 or 10 areas of how to increase productivity or to enhance your productivity. So hopefully as we went through today, you were able to find some areas that maybe you say, yeah, we're doing that, we're doing good. And maybe you found some areas that, yeah, we probably should think about that, and thinking about those areas that can assist you in getting your productivity hopefully back up to where you were and maybe even enhance it from there. And so that's some things that I think that might be helpful for you. We are out of time today. We have gone to the very, very end with this. If you have already submitted questions, we will go through after the presentation and we will respond to those. If you have any questions after the session, please let us know, and we will be happy to show you more about TruCode or be able to talk to you more about how we can assist you in the future. Remember, if you came on late today, please remember that you will get your CE certificates tomorrow. It won't come out today. You'll get your CE certificates tomorrow. And again, if you didn't hear at the very beginning, in the bottom of the control panel, it's got your handout. So go to the bottom of the control panel, click on the handouts there, and that will give you the printed handouts. Well, thanks again for sharing your hour with us today. We certainly appreciate you being with us, and we hope this has been beneficial for you. And from all of us at TruCode, thank you, and have a wonderful rest of your day. Bye now.